Good afternoon. Welcome to This Is Your Brain. Dr. Ramakrishna, please go ahead and get started.
Hey, everyone. Thank you for joining. My name is Dr. Rohan Ramakrishna. I am a neurosurgeon at Weill Cornell Medicine and a brain tumor specialist. I'm joined by Dr. Catherine Beal, who is a welcome new addition to the Weill Cornell Medicine family. Dr. Beal, do you want to introduce yourself?
Oh, yes. I am Dr. Catherine Beal, and I've been treating with radiation for brain tumors for about 20 years. I was at Sloan Kettering for 21 years, including my training, and recently joined here as the director of the Brain Metastasis Center with Dr. Ramakrishna and director of our Gamma Knife.
Wonderful. So today what we're going to talk about is metastatic brain tumors. What are they? What do we do for them? And really, this is a disease for which many years ago often resulted in really poor outcomes for patients, unfortunately. But the treatment options we have nowadays are really paradigm shifting from the standpoint of being able to take care of patients with brain tumors, brain metastases, and as well keep them with a great quality of life. I want to thank Dr. Stieg for inviting us to this seminar. So the first thing is, what is a brain metastasis? A brain metastasis fundamentally is a cancer that's spread from one part of the body into the brain. Most commonly, the cancers that spread to the brain and spine include lung, breast, melanoma, renal cell, and you see the list of other cancers that can go to the brain, for example. And really any cancer can go to the brain. And nowadays we've seen that as the therapies for many of our other cancers get better and better, it unfortunately sometimes creates an opportunity for these tumors to enter the brain. And that's because of the blood-brain barrier. A lot of the cancer treatments that we have can't get into the brain because the brain is really good at keeping out toxins like chemotherapy, for example, or not necessarily immunotherapy, but very large antibody-based therapy, for example. So because of that, the brain is particularly can be a challenging site to treat because of the fact that the blood-brain barrier keeps out these chemotherapies. And historically, what's been a challenge is that anytime you had a brain metastasis, whether it was from lung, breast, melanoma, it was often just treated as a brain metastasis rather than one that was specific to lung, specific to breast, specific to melanoma. But that's increasingly changed over the last 5 to 10 years. And now the good news is we're having increasingly tailored options that can really benefit patients depending on the type of brain metastasis that they have. Now, the great news is we've come a long way, as I've mentioned before, relative to when brain metastases therapies really began. And, from this RTOG study, which was based on 1,200 patients from, the 80s and early 90s, the median survival of patients who, had a brain metastases was measured in months. And the great news is we have made incredible strides. We have patients with brain cancer metastases. I have patients with brain cancer or breast cancer brain metastases, for example, that are 20 years out from the diagnosis of their metastasis. But we still have a long way to go. And part of that depends on prevention. Part of that depends on diagnosis. But we know that the prognosis in terms of whether someone develops a brain metastasis and how they do with the brain metastasis depends on where the tumor comes from, the subtype of the tumor, and how they're doing from an overall standpoint, from the standpoint of their cancer. Do they have a lot of cancer spreading in the rest of the body? Are they very symptomatic? Is it really impeding their quality of life? All of those things really come to bear on how someone will do if they're diagnosed with a brain or spine metastasis. Why does all of this matter? Why do we care about trying to predict how someone might do, how the rest of the body is doing when we come up with brain metastases treatment? It's because these kinds of data points really help us individualize and tailor how we're going to treat patients with brain metastases. So if I give you this example, this is a 45-year-old female with a metastatic breast cancer brain metastases, which you can see in this MRI image here in the right occipital lobe. Occipital lobe is part of the brain that deals with vision. And there's, I'm painting multiple scenarios here. One where KPS stands for Karnofsky performance status, and that reflects, what your quality of life is, how independent you are, and 100 means that you're essentially doing perfectly. So in that kind of person with no other sites of disease, it makes a lot of sense to be really aggressive here and, potentially remove it with surgery, and then follow that up with radiation to prevent it from regrowing. But if you have someone on the flip side who is doing, has significant cancer elsewhere in the body, like in the abdomen or the gut, they're not really feeling well, doing well. Does it make sense to stop their therapies to do a surgery? I would argue no. And really, we should continue them on or try different therapies that we can give systemically. So this is why it's really important to figure out how the patient is doing overall and how we can tailor our recommendations for brain metastases care on that basis. And so when it comes to what our goals of therapy are, when it comes to brain metastases, we want to control the sites of disease that we see. That's what local control refers to. But we also want to try and prevent future sites of disease in the brain, because you can, even if you develop a brain metastases in one part of the brain today, there's still the possibility that you could develop it in another part of the body tomorrow, or another part of the brain tomorrow. So those are considerations whenever we're treating patients. Similarly, we want to make sure that we treat symptoms. And, oftentimes brain metastases can cause a lot of swelling, which we call edema in the brain. And depending on where that edema is located, for example, if it's in the temporal lobe, you might have seizures or speech difficulties. By taking out and treating the brain metastasis, we can reduce the swelling and hopefully reduce the symptoms. Now, in terms of treatments for brain metastases, historically, we had one, which was radiation therapy, like whole brain radiation therapy. But mercifully, we have lots of new treatments now. At Weill Cornell Medicine, we've had a great multidisciplinary group. Just some shameless self-promotion. We had a book we published a few years ago, which is a contemporary management of CNS brain metastases. And the point there is just to make that there's many, many, many options now for patients with brain metastases outside of whole brain radiation therapy, which we really try to avoid because it can cause some serious neurocognitive side effects. And so we talked about surgery. There's also radiosurgery, which you're going to hear a lot about, which is very focused direct radiation to the abnormalities in the brain. Combination therapies, where we combine surgery with other therapies like brachytherapy. Brachytherapy is when we're implanting radioactive seeds in the brain, and basically can deliver radiation in the brain at the time of surgery so that people don't have to come back for other radiation sessions. And there's certain situations where that can be really useful. And then immunotherapy and chemotherapy or targeted therapy. In the age of melanoma now, a lot of our immunotherapy strategies will work in the brain. There's good evidence that in the landscape trial for breast cancer brain metastases that capecitabine in HER2 positive patients can be useful for patients with brain metastases, although there is some side effects associated with that. So the bottom line is this is only going to get better and better over time, which is great. One thing before I'm almost done here. One thing that we really want to try and do is really target therapy. That's what we talked about earlier in this talk. And the reason for that is that the genetics of the tumors in the brain can be different from the genetics of the primary tumor. So what does that mean? So if you have a breast cancer, let's say, and that has a certain set of mutations, mutational profiling is commonplace at any advanced cancer center because we look at mutations to figure out, is there a targeted therapy, a precision medicine therapy for you specifically, and try and deliver treatments on that basis. Now, the problem is sometimes the metastases, like the brain metastases, can be slightly different from the primary tumor. In the example I'm giving, the breast cancer. So if we take a biopsy or remove brain metastases, we can profile those tumor tissues and really see, is there a specific therapy for the brain? And I think this is really going to be part of the future of brain metastases care, where we specifically go after the brain metastasis tissues so that we can see, is there a targetable mutation for which we can give systemic treatment for. So in terms of how we decide who needs surgery, it's really, can you tolerate a surgery? We want to make sure that from a heart, lung perspective, there's no real contraindication or big side effect profile from you having surgery. The situations where we try not to do surgery is where, or we really think hard about it, is if it's really going to interrupt your therapy and doesn't make sense from that standpoint, because we don't want you to stop really important therapies just so you can have a surgery for one site in the body. So, it's a case-by-case basis, but we want to really be thoughtful about when we offer surgery to patients. We have lots of different techniques for doing surgery. When we remove things in 2023, this picture here shows tractography, where we can show the white matter tracts that connect the brain to the rest of the body. So we can image them before surgery and make sure we protect them during surgery. We can also use lasers, so-called lip-based therapy, to heat up very deep-seated tumor tissue in the brain. This can be really useful for parts of the brain where it's hard to access from traditional surgery. And then brachytherapy, as I mentioned, where we implant radiation seeds in the brain to deliver radiation at the time of surgery. Almost done here before turning it over to Dr. Beal. I think surgical technique is something that's incredibly important. That's where we really try and remove these tumors as one big piece rather than in multiple pieces. And when we do that, that results in much less in the way of tumor spread after surgery. And that's something that at any brain tumor center you should make sure is done as sort of a standard treatment. When surgery is being offered, we talked about if a metastasis ever comes back, we can really deploy all of these things again if necessary. And so we, again, in an effort to tailor and treat symptoms and prevent things from regrowing, we have an arsenal of options available to us. Just quickly to show some cases, this is a 49-year-old male who had a melanoma brain metastases, 2 of these. And as you'll notice, they're not too big. You'll have to take my word for it. And so we had opted to treat him with radiosurgery, which you're going to hear a lot about, which again is this focused treatment for radiation, very focused radiation treatment for brain metastases. But when he came in for his radiosurgery, he became increasingly symptomatic, trouble speaking, new vision problems. And so we got a new scan, and basically his tumors had hemorrhaged, which sometimes happens with melanoma. And because they gotten so much bigger, we decided to take him to the operating room and remove those tumors and then do radiation thereafter. And he's still doing well, thankfully. But the advantage of doing surgery in these kinds of cases is that, number one, you take out these masses, which relieves the mass effect in the brain, and it rapidly reduces the swelling, so you can get off steroids. We could do a whole session on steroids, but steroids can cause a lot of side effects related to insomnia, diabetes, things like that. And so we really want to try and get people off these therapies as quickly as possible. Similarly, these metastases here are in the parts of the brain near and dear for language, and then also facial motor movements. And so the way we can take these out safely is by doing a procedure called mapping, where we map where the language parts of the brain are. You're awake for that, but don't worry, it's not painful. We give you lots of medication to prevent any scalp pain. But in doing that, we can protect your language centers and remove these kinds of tumors safely. So with that, I will turn it over to Dr. Beal. We'll talk more about stereotactic radiosurgery.
Great, thank you so much. Okay, can you see my screen?
Yep.
Great. Okay, thank you. It's a pleasure to be here today and to speak to you all about radiation for brain metastasis. So as Dr. Ramakrishna mentioned, if a patient presents with a larger brain metastasis that is inducing symptoms, it's often necessary to remove the tumor surgically. Or if we don't know what the pathology is, what type of tumor a patient may have in the brain, that may be another indication for surgery. But fortunately, most patients with brain metastases don't present with symptoms or significant symptoms that need to be removed surgically. And the majority of patients also, if they are diagnosed with a brain metastasis, most of the time we do know what the pathology is. So there are many, many patients who present with brain metastases who don't need open surgery, but they may benefit, and most of them do benefit from radiation. And there are different forms of radiation that we use for brain metastases. There's something called stereotactic radiosurgery, which is what I'm going to focus my talk on mostly today, and then also whole brain radiation, which, as the name implies, treats the whole brain. So the number of patients diagnosed and living with brain metastases is increasing each year in the United States, and it's estimated that there are up to 400,000 new cases per year in the United States, with about 30% of patients with advanced solid tumors developing brain metastases. The incidence of brain metastases is really rising for two main reasons. One, we are starting to screen more patients that we are concerned may develop brain metastases, and we also have better imaging with finer, detailed types of imaging like MRI, which can detect smaller brain metastases. So we're finding these tumors when they're smaller and earlier. Also, patients are now benefiting from better systemic treatments, by which I mean more types of chemotherapy and what we call targeted therapy, and also drugs like immunotherapy, which lead to longer survival for patients, even if they have advanced cancer. And patients then have more time to develop brain metastases. In the present day, contemporary patients are more likely to be diagnosed with a limited number of brain metastases. Some are likely to show up with 1 or 2 or 3 brain metastases than in the past, when we didn't have as good as systemic treatments. Patients were more likely to present with many brain metastases. Patients with a few brain metastases are very likely to benefit from stereotactic radiosurgery. So due to both improved technology and prognosis of patients, there's been a massive shift away from whole brain radiation therapy, and the use of stereotactic radiosurgery is rising for patients with brain metastases. SRS offers many benefits, but one of them is that it offers better control per brain metastasis, and it also leads to reduced toxicity over whole brain radiation. As Dr. Ramakrishna mentioned, however, many patients who are diagnosed with 1 or more brain metastases eventually develop other brain metastases. And so if we use a targeted treatment to treat a brain metastasis, about 50% of the time, patients will eventually develop another brain metastasis, but this can often be salvaged or treated with another course of stereotactic radiosurgery. So one of the important jobs of a neuroradiation oncologist or a neurosurgeon is to follow patients closely after we've treated their brain metastasis to catch potential other brain metastases when they are very small, so that we can treat them efficiently and effectively with reduced risk of toxicity. So what is stereotactic radiosurgery? It's a pinpoint type of radiation treatment which treats just the tumor itself. So this is a axial cut of a brain MRI, which is basically a slice through a patient's brain at about this level. And this patient has a tumor in their right frontal lobe, so right behind where my finger is here, that's measuring about 1 centimeter in greatest dimension here. And we have a very efficient and effective way of treating just this tumor with high dose radiation, typically given in 1 dose. And the radiation is delivered only here. The rest of the brain is delivered any significant dose of radiation. And it's achieved by delivering many, many little beamlets, innumerable numbers of little tiny beams that all converge on this target right here. This just demonstrates a theoretic plan of radiation where all these little beams of radiation are converging on this red target here, corresponding to this tumor here. So there are many different types of stereotactic radiosurgery systems. There are machines called TrueBeam. Varion's a big producer of linear accelerators. And the TrueBeam is a linear accelerator which uses photons that are delivered from this machine here. The patient lies on a table here. This gantry rotates around the patient, and the table also moves into many different positions. There's also a system that many people have heard of called the Gamma Knife, which is produced by a company called Electa. And a Gamma Knife also is radiation using photons. And a ZAP is a new type of system. Again, one of many types of systems that's unique in that it's, again, a linear accelerator, but it has its own shielding mechanism immediately around the machine, so it doesn't require an entire vault. A Gamma Knife and all linear accelerators are otherwise all maintained inside a large vault to protect any of the radiation from escaping the room. And this system actually has its own vault built around it, which is actually unique, which is why I bring it up. In any case, from a patient perspective, all of these systems are similar in terms of the patient experience. The treatment per lesion and per brain is equivalent in terms of the effectiveness. All of these systems have something called image guidance, so that during, just prior to treatment, we can image patients while they are on the machine, and all to ensure that the setup's proper. And all of these systems also have motion monitoring systems, so that we're monitoring patients during treatment to ensure that they're not moving. You can see that there is a mask system that's unique to each system here, all these different treatment systems. But these mask systems are also now quite capable of fixing patients in place, so there's very little motion possible. If a patient, however, moves more than 1 millimeter or 1.5 millimeters during treatment, we have systems that detect that and will stop the beam immediately, automatically, then we will resume treatment once we've realigned the patient into the proper position. So jumping ahead, we have started using stereotactic radiosurgery as a routine treatment for patients with many brain metastases. In the past, we had to use a fixed brain system, which was bolted into the patient's head for the day. And when we had that system, we were only able to treat 1 to 3 brain metastases for technical reasons. And so we went back originally and started looking at some of our results when we started treating with stereotactic radiation more routinely. And our original, one of our original analyses from across the street was looking at patients who we knew had relatively good outcome after having their breast cancer brain metastases treated with stereotactic radiosurgery. So this was a cohort of patients in the early 2000s, so between 2000 and 2009, who had 1 to 3 brain metastases from breast cancer. And we looked at some of the pathologic and other clinical factors of each person's cancer. And there were 67 patients with a total of 116 brain metastases. All these patients had relatively long follow-up of almost 6 years. And the patients we found had an excellent survival if they had certain good factors. So what were those good factors? We looked at how many lesions a patient had. If they had 1 brain metastasis as opposed to 2 or 3, they had a better outcome. Likewise, if they had HER2 amplification in their pathology, meaning they had cancers that could have hormone receptors or not, but they all had HER2 amplification, we found that those patients likewise had a better outcome. And also we looked at whether or not they've had extracranial disease that was absent or stable in the rest of their body, or active disease elsewhere in the body, meaning that they have lung metastases or liver metastases or other types of metastatic breast cancer in their body that was growing. And if they had absent or stable disease elsewhere in their body, they likewise had a relatively high score of 3. This is a point scoring system where we gave points for each of these factors. So how many brain metastases they had total, whether or not they had HER2 amplification, and whether or not they had extracranial disease, absent, stable, or active. And if they had the good features, they got a higher number of points. And the best group were patients who were in group 4 and had a total of 8 to 8.5 points. And these patients had what we call a median overall survival of 45 months, which is rather remarkable, because prior to the area of HER2 amplification identification and also the targeted drug called trastuzumab or Herceptin, these patients did not live nearly as long. Now, with the benefit of one of these targeted agents, it's an antibody therapy that recognizes breast cancer cells that have HER2 amplification and is highly effective for those patients with that type of cancer. Those patients have excellent control of the disease in their body. And if they develop brain metastases, we are very effective at controlling their brain metastasis with stereotactic radiosurgery. So this is a survival curve here in the bottom right, and it demonstrates the different groups of patients. So the group 4 patients who have the best or most highest points in this scoring system have the best survival here. The patients in group 1 have the lowest survival. I also wanted to point out that the size of the brain metastasis that you treat with stereotactic radiosurgery matters. If a tumor is under a centimeter or up to 9 millimeters, you can see that the local control is in the range of almost 90% long-term. So 2 years and out, there are very few failures or recurrences of these relatively small tumors treated with stereotactic radiosurgery. If the tumors are larger than a centimeter, the local control of each tumor is actually only about 50% by the time you're 2 to 3 years out from stereotactic radiosurgery. So in general, if patients are diagnosed with brain metastases, our great preference from a radiation oncologist standpoint is to treat those tumors when they're smaller, in the range of a centimeter or less. Sometimes, however, patients present with larger tumors, and we will, again, treat them relatively aggressively with stereotactic radiosurgery, assuming they don't need surgery, and follow them closely. If they do have a failure or the tumor regrows, we might call for a consultation from one of our neurosurgeons to see if we should add surgery or perhaps just repeat radiation. I also wanted to mention a great success story with brain metastases, and that is patients who have melanoma brain metastases. 10 years ago, patients with melanoma brain metastases survived on average only in the range of about 3 to 4 months. And we now have patients who are cured of melanoma brain metastases. And that is because of the great, wonderful advantage of adding immunotherapy, which are drugs that stimulate a patient's own immune system to help attack the cancer. These types of drugs are relatively effective in aggressive cancers like melanoma. And melanoma also responds relatively well to radiation, particularly when the radiation is delivered with stereotactic radiosurgery. We recently presented our results looking at patients who survived at least 5 years after their treatment of their melanoma brain metastases. And this is absolutely stunning that patients who are treated more than 5 years before are surviving long-term and appear to be cured. So what's interesting about this is the survival curve, 60 months or 5 years out from radiation. And these are patients who are now in their 70s. and their survival after more than 5 years out from their brain radiation continues actually at a relatively high rate. The patients are not dying at this point of their melanoma brain metastasis, but they're dying of other causes unrelated to their cancer, which is remarkable. Also, interestingly, as we've mentioned a few times now, many patients who develop one brain metastasis or even two initially might die or eventually develop other brain metastases. And that's not necessarily a bad prognostic feature in terms of survival. Almost 50%, this is 100% of the patients here, almost 50% of them over time developed a second brain metastasis after treatment of their first brain metastasis. Yet the same group of patients really had a very excellent survival and outcomes. And this development of another brain metastasis did not seem to impede or hurt their chances of survival. One other very interesting aspect of these patients in particular is that they had a very high rate of something called radiation necrosis. So scar tissue development after radiation, high dose radiation, is not very common. About 10% of patients might eventually develop some scar tissue in the area that we treat with the high dose radiation, but won't necessarily have symptoms from it. In this group of patients who had the immunotherapy and high dose radiation, a full 25% of them had large scar tissue development after their brain radiation and developed symptoms and needed to have that scar tissue removed, which is a very, very high number of patients. In general, we only need to remove about 3% of brain tumors for scarring after radiation. And in this group of patients, we had to remove about 25% to control patients' symptoms. And that's because when you combine high dose radiation therapy with immunotherapy, you actually get a very robust reaction fairly frequently after treatment. Interestingly, that also portends a very good result for these patients because it means they've got a robust immune response to the treatment we're delivering. So here's a patient who had immunotherapy to this brain metastasis right here. So the immunotherapy was delivered in March of 2009. She then had stereotactic radiosurgery right afterwards to this tumor only. And then in September of 2009, 6 months later, the tumor was relatively stable, perhaps a little bit smaller than it was at treatment time. And then a few months later, she developed some changes of the area that was treated as well as seizures, and eventually had surgery to remove this area of question and was found to have no active tumor. She had necrosis alone. This was in the era of when we were just starting to give radiation and immunotherapy together. Here's another patient with presumed necrosis who received stereotactic radiosurgery concurrent with immunotherapy called ipilimumab. The tumor eventually, just 2 months later, developed some swelling around it, as well as some bleeding within the tumor. The patient was asymptomatic, meaning he didn't have any symptoms related to these changes. So we elected not to operate, but just to observe the tumor. And there was gradual contraction without any treatment or intervention. And over time, there was continued contraction, and the patient never developed any sign of metastatic melanoma again. And 6 years later, after this original treatment, the patient is without any evidence of disease in their brain or body. Here's another patient of mine. This is one of my favorite examples, who had a few brain metastases. And interestingly, the very smallest one that we treated was this one right here, less than a centimeter. It's probably about 5 or 6 millimeters in greatest dimension. This was treated with stereotactic radiosurgery with concurrent immunotherapy called ipilimumab. 6 months after treatment, the patient developed asymptomatic necrosis. So you can see this is the swelling around the area, and this whole bright area is all scar tissue. It looks classic on the MRI for the radiation necrosis. We elected to observe the patient. There was no active intervention. This whole area naturally contracted. And the most current MRI, more than 10 years after his treatment, looks like this. And the patient has continued resolution of his necrosis and remains without any evidence of disease in his brain or body, more than 10 years out from his 3 brain metastases from melanoma. I also wanted to mention another area of or type of brain metastasis, which is from renal cell or kidney cancer. And likewise, renal cell or kidney cancer brain metastases tend to be relatively aggressive. And very recently, we've started to see patients who are doing relatively well. Many patients eventually develop several brain metastases. And similar to melanoma, they're very obvious brain metastases, very enhancing. They often have a lot of swelling around them. And more recently, there have been 2 changes in the standard of care for patients with kidney cancer that's advanced to other areas in their body. And that is that we give these patients immunotherapy, similar to the melanoma patients. And we also give them drugs that inhibit something called VEGF, which is a material that tumors release that cause a lot of swelling around them. And when we treat the combination of these VEGF inhibitors and immunotherapy with stereotactic radiosurgery to these tumors, we're seeing a dramatic response. And this is an example patient of mine who came in with very significant neurologic symptoms related to his 7 relatively large brain metastases with a lot of associated edema. He underwent stereotactic radiosurgery, immunotherapy, and the VEGF inhibitors all together. And within a few months after his treatment, his tumors all resolved. This is 6 months later. There's an absolutely complete response of his 7 large brain metastases. All of his symptoms responded and resolved, and he remains without any evidence of disease about 2 years out now. So in my final moments here, I'd like to also describe the role of giving radiation after surgery for brain metastasis. So again, if a patient comes in with a large tumor with a lot of symptoms, they will often have surgery. And even with the best neurosurgery possible, we know from clinical studies that there is still a chance that even after the tumor is removed, there may be some cells remaining in the normal brain just outside of where the tumor was removed. If we don't add radiation therapy, there's about a 50% chance that tumor may regrow. But if we add radiation therapy to the area where the tumor was removed, it's reduced down to about 10%. We used to treat all patients who had brain metastases removed with surgery with whole brain radiation therapy. And about 15 years ago, we designed a study that instead of treating the entire brain with radiation, just treated radiation to the area where the tumor was removed. And we found that the patients who underwent that treatment actually had a relatively good local control. At about a little more than a year out, their local control rate of the area with surgery and radiation was in the range of about 80%. And many of these patients were actually relatively sick otherwise. And so their survival at a little more than a year out was actually only in the range of about 50%. So we were better able to control the area that was treated than we were doing a better job at controlling their brain essentially than controlling what was going on in their body. So we were pleased with that result, and the advantage of treating just the area where the tumor was removed is it's much less toxic for patients than treating their entire brain. So since we developed that study, that became the standard of care. I'm going to skip over this slide and move on to show you a classic patient with a relatively large tumor that's very appropriate for neurosurgery to remove. It's a large tumor. There's a lot of associated edema and swelling, which was certainly causing this patient significant symptoms. She was a 50-year-old woman who came in with right-sided weakness related to this tumor on the left side of her brain. And so she had it removed with surgery, and this is the post-operative cavity, the area where the tumor was. And about 4 weeks after surgery, she had a single dose of radiation, stereotactic radiosurgery to this cavity. However, unfortunately, this patient eventually developed some recurrent disease here about 9 months after her radiation. And you can see the recurrent disease is its bright white area here and here. When we were treating in this era with this clinical study, at that time, we were using what's called fixed frame stereotactic radiosurgery, where we would fix a frame into a patient's skull. And with that type of treatment, we had the only option was to treat with 1 dose of radiation. Now that when we use removable frames, we can treat with 3 or 5 doses of radiation, which is a little gentler to the brain. And if we're using a little gentler approach, we can actually use a larger area and cover a much more broadly and generously in this era. So what we also learned from this study is that it's a better treatment to treat, instead of just treating tightly to this cavity and with 1 dose of radiation, we now treat a much larger area along here and have better success with these types of tumors. So as I was just mentioning from this study that we did, we found that extended margins are needed for large superficial tumors. So what we call hypofractionated radiation for surgical cavities that are superficial with a we treat that with a wider margin along the dural planes. And we've now much better results for post-operative radiation therapy. More recently, there's been a push to look at offering radiation therapy before surgery. And there are 2 main reasons for that. One is that there may actually be some advantages in targeting. If you can see what the tumor looks like before surgery and you know what the high risk area is, we can target that before the patients undergo neurosurgery. In addition, when we treat preoperatively, we think there's a little lower rate of developing scar tissue because you have better vascularization of the area. So based on those 2 observations and theories, there are several ongoing randomized trials of preoperative versus postoperative radiation therapy in the United States and around the world. Finally, I'd like to point out that there's been very importantly a wonderful collaboration between neurosurgery, radiation oncology, medical oncologies, neuroradiology, and neuro-oncologists to really start studying the science and understanding the biology of brain metastasis as a separate entity, not just a complication of having cancer. And there's been concerted interest as well scientifically with this special group of patients. And we've also realized that there's a very important value in collaborating together and treating these patients relatively efficiently in a shorter period of time, which leads to better control. And we've got a great team here at Cornell that enables us to do that and deliver the best care possible to take care of our patients' brains. Thank you so much. I think we can take questions now. Dr. Ramakrishna, I'm going to hand the screen back over to you.
Yeah, thank you, Dr. Beal. It was awesome. If you have questions, put them in the chat while we're waiting for that. One other exciting area, that's developing is this idea of, adjacent to the idea of immunotherapy is this idea of kind of promoting the abscopal response. So our colleague here at Weill Cornell, Sylvia Fermenti, is the chairman of radiation oncology, has been national leader in this. There's a clinical trial here looking at targeting patients with multiple brain metastases with immunotherapy and only 1 or 2 sites of radiation. And the idea being that the combination of radiation immunotherapy can induce the body to start attacking all the other tumors in the brain because of what we call increased antigen response that's delivered because of the radiation. So we've seen some tantalizing results with that. That's ongoing, but that's a really exciting area of inquiry because it means that if it works in certain patients, you can have a lot less radiation, number 1, and 2, you can really start this idea of incenting the immune system to go after and attack a lot of other tumors elsewhere in the body. So that's something that I think we'll have more to come on.
I have a question here from somebody. It was a direct question to me. And the question was, how many times can you use SRS for a brain tumor? Can we repeat stereotactic radiosurgery? So as we both mentioned, a patient might present with 1 or 2 or 3 or 5 brain metastasis, and they may need surgery, and they will certainly need stereotactic radiosurgery. And then after stereotactic radiosurgery, we'll follow the patients very closely with routine MRIs, typically about every 2 months. And there's about a 50% chance that the patient may eventually have developed another brain metastasis elsewhere in their brain. And we can give repeated courses of directed stereotactic radiosurgery. I have some patients where I've treated more than 40 brain metastases over time, perhaps over a number of years. If one of the first or subsequent brain metastasis recurs, we then have several options. We sometimes will repeat radiation, directed radiation just to that tumor. Sometimes we'll remove it surgically. Sometimes we'll add new or different drugs in combination with radiation, but there are thankfully, several options now. There's also a technique Dr. Ramakrishna mentioned called LIT, which the surgeons will sometimes use to address a recurrent tumor. There are several protocols ongoing at major academic centers around the country as well, looking at those different options.
Thank you. Another question, what about leptomeningeal disease? What is it? What do we do about it? So that's a great question. Leptomeningeal disease is, a type of brain metastasis where the tumor is spreading across, the lining of the brain and in the crevices of the brain in the arachnoid areas. And that's more difficult to treat only with radiation because it tends to be much more diffuse. And so in those situations, there's active research to look at what can be done to be more effective. Sometimes radiation is part of the answer. Sometimes it can be what we call intrathecal therapy, where we give medication in the spinal fluid. Sometimes systemic therapy can be effective. So it's really a tailored approach, but that's an area of active investigation. Dr. Beal, do you have anything to add to that?
Well, leptomeningeal disease is generally a challenging diagnosis, but depending on the type of cancer, we do have some medical therapies that are relatively effective. And as you mentioned, another option is to treat just the symptomatic areas with radiation, or we do on occasion treat the entire brain and spine with radiation, which can be useful for some patients. Fortunately, leptomeningeal disease is not very common. And there's sort of a range of possibilities of what may happen with these patients.
Next question is there a age limit to doing SRS, either older or younger? So no real age limit at the older end of things. If as long as someone wants to pursue treatment for their brain metastases with us, we can usually make it work. On the children's side, it can be done. Children tend to have different cancers than adults, and so but radiosurgery can be used in certain situations.
In fact, we tend to favor stereotactic radiosurgery over whole brain radiation therapy for older or elderly patients in particular. Whole brain radiation is an effective form of treatment and appropriate for some patients with what we call miliary or many brain metastases. But for older patients in particular, we prefer to treat with the pinpoint radiation because whole brain radiation is more likely to cause some toxicity that older patients are particularly susceptible to, a particularly short-term memory loss.
Awesome. Last question is, who decides what treatment each patient gets? And so, it's really a multidisciplinary approach, as Dr. Beal mentioned. Sometimes it's just very obvious someone needs surgery, for example, because it's a huge tumor with a ton of swelling, et cetera. But really, every patient that comes through our doors gets multiple people laying eyes on it, whether it be radiation oncology, neuro-oncology, medical oncology, neurosurgery, neuroradiology. And that way we can make sure we come up with the best treatment for every patient. So in general, what happens is oftentimes if you're diagnosed with a new brain metastasis, it can be either because you're symptomatic, and so you get a scan of your brain, and then your medical oncologist will loop in the rest of the team that I just mentioned. Or sometimes your oncologist will order scans to be proactive and see if there's any metastases in the brain, because certain cancers are so, are very likely to have brain metastases. And again, if the one is discovered, then he or she can loop in our team. So it's really your medical oncologist or neuro-oncologist who, like everything else, is your general contractor. But when it comes to driving your brain metastasis care in particular, it's your neuro-oncologist, your neurosurgeon, and radiation oncologist. Is the method of anti-neoplastin by Dr. Brzezinski still viable? If I'm thinking of who you're referring to, there's a cancer clinic in Houston. I don't know too much about it, so can't really comment.
I'm not familiar with that either. I was hoping you could answer that. But there are many agents that we purposely use with stereotactic radiosurgery to enhance the response to radiation. For instance, as I mentioned, the VEGF tyrosine inhibitors, either in the form of pill versions or some infusions with a drug called Avastin or bevacizumab, are known to be very useful with high dose radiation. As I mentioned, also immunotherapy as a general approach helps to stimulate your immune system, which works very well in conjunction with high dose radiation. So when you give a big dose of radiation, you actually cause an inflammatory reaction right at the tumor site, and the tumor is obliterated with the radiation, releases its own proteins into that area of the brain. The cells are dying and releasing foreign material into the brain. And when your immune system is revved up, those immune system cells will come to that site where the antigens or proteins from the cells are leaked into the brain. And it helps, the revved up immune system comes to help create a reaction at that site that will help control and obliterate that tumor. So we are very purposely combining many different types of therapies that are given either orally or intravenously with radiation and seeing rather astounding results. I'm sure there are some other alternative therapies that are probably useful with radiation. Most of them, those are not studied in very rigorous clinical trials. And that doesn't mean they don't deserve some consideration. But most of our standard approaches to cancer care are based on rigorous clinical trials that show us the safety and efficacy of the treatments that we now propose.
All righty. I think that is it in terms of questions. I'll hold it open for another 10 seconds if anyone has any burning inquiries. But I want to really thank Dr. Stieg for inviting us, Dr. Beal and I, to talk about brain metastases care. We are at your service if there's anyone that we can help in your families. I hope no one in your family ever develops a brain metastasis or brain tumor, but if that becomes an issue, of course, we're happy to help. Shouldn't point out that the Gamma Knife icon is our new flagship device that we've installed at Weill Cornell just recently, and is working really, amazingly. So thanks to the huge team that makes it happen every day. And like I said, be in touch if we can help. with you and your families. Thanks again.
Thank you.